Hello everyone, today we'll be talking about retinoblastoma. Retinoblastoma basically refers to a malignant tumor that arises from the neurosensory retina in one or both eyes. So basically what we mean is that the retinoblastoma, it can be unilateral affecting one eye or bilateral affecting both eyes. Demographic data. So the prevalence of retinoblastoma is it's the most common intraocular tumor of childhood, occurring 1 in 15,000 to 20,000 live births. And for the age, so basically retinoblastoma is confined to infancy and very young children, and it's usually seen between 1 and 2 years of age. There is sex, so there is no sex predisposition, so it equally affects males and females. Race, so it's rarer in Negroes than whites. 5. Bilaterality. So in 25 to 30% of cases, there is bilateral involvement, although one eye is affected more extensively and earlier than the other. So they said that 25 to 30% of cases, both eyes may be involved, right? But then what you're going to notice is that one eye will be affected more than the other. Genetics. So basically, retinoblastoma gene, it has been identified as 14 band on the long arm of chromosome 13. So if they ask you what chromosome is affected, it's chromosome 13, the long arm, okay? And it's a cancer suppressor or anti-oncogenic gene, but we commonly like calling tumor suppressor genes. So a few facts. So of all cases, only 10% are familial, which is only 10% are inherited by autosomal dominant mode, and the rest, about 90%, they occur sporadically. Then of the sporadic cases, about two-thirds, which is about 60% of all cases, they occur by somatic mutation, and out of which one-third, which is 30% of all cases, occur by germline mutation. So therefore, retinoblastoma it either occurs as heritable cases, which is 40%, or non-heritable somatic cases, which is 60%. So why is this important? Basically, if a child has retinoblastoma, right? So you always need to consult the parents. You need to tell them that these are high chance. Maybe compared to others, the next child may also have retinoblastoma. Also, there is a high chance that their children might also have retinoblastoma, as in the child that's affected once they grow up and they have children. There is a high chance they may also pass on the gene if they got it inherited, if they inherited the gene. Okay. So, pathology. Origin. Retinoblastoma arises as malignant proliferation of immature retinal neural cells, which are small round cells with large nuclei. Okay, take note. Small round cells with large nuclei. So, under histopathology, the tumor chiefly consists of small round cells with large nuclei, resembling the cells of the nuclear layer of retina. These cells may present as a highly undifferentiated or well differentiated tumor. Microscopic features of a well-differentiated tumor include flexner intestinal rosette. These are highly specific for retinoblastoma. So what are these? Highly well-differentiated tumor include flexner intestinal rosette. Then those other findings we have are homocyte rosettes, pseudo rosettes, and florets formation. Other histologic features are presence of areas of necrosis and calcification. So this is a diagram showing the specific rosette that we were talking about. So this is the flexner rosette, and this is highly specific for retinoblastoma. Then this is a diagram showing the homocyte rosettes. These are undifferentiated tumor cells. Clinical features. So common presenting features of retinoblastoma can be described stage-wise as below. So one intraocular stage of retinoblastoma, presentation of this stage, it can be divided into two subgroups. So we have a quiescent presentation and a painful red eye presentation. So what are we saying? So there are two stages, okay? So the first one is intraocular stage of retinoblastoma. Then the intraocular stage is divided into two subgroups, whereby we have got the quiescent presentation and the painful red eye presentation. So the quiescent presentation includes leukochoria, or the yellowish-white pupillary reflex, which we commonly also call amaurotic cat's eye appearance, and it's the commonest presenting feature, which is it presents in about 60% or even more patients. Okay. So this is what we talk about the yellowish red pupillary reflex. This is what we call leukocaria. Two, squint. So the squint is usually convergent and it's the second commonest mode of presentation. Three, nystagmus. It's a rare feature and it's commonly noticed in bilateral cases. This is whereby both eyes are affected. For defective vision, so this is very rare and this is when the tumor arises late, which is between 3 to 5 years of age. The child may complain of defective vision. 5. Ophthalmoscopic features of the tumor. In the early stages before the appearance of leukocaria, fundus examination after full mydriasis may reveal the growth. So basically, a child comes to you, they do not have leukocaria, basically they do not have any obvious clinical findings. So if you do ophthalmoscopic exam or fundus examination, you may be able to notice the malignancy, the tumor. So presenting features in terms of percentages, we've got leukocaria, which is 60%, strabismus 20%, painful red eye 7%, poor vision 5%, asymptomatic 3%, orbital cellulitis 3%, unilateral mydriasis 2%, heterochromia iridis 1%, and hyphema 1%. So ophthalmoscopic signs that are seen in three types of retinoblastoma are as follows. So one, endophytic retinoblastoma. So this one grows inwardly from the retina into the vitreous cavity. If you're able to notice this tumor, it's going well from the retina into the vitreous cavity. You know, this is the vitreous cavity, right? Then on ophthalmoscopic examination, the tumor looks like a well circumscribed polyploidal mass of white or pearly pink color. You're able to see this. Then fine blood vessels may be present on its surface. And in the presence of calcification, it gives the typical cottage cheese appearance, and there may be multiple growths projecting into the vitreous. So this is what we're talking about, the fine blood vessels that are present here. To exophytic retinoblastoma. So this one grows outwards and separates the retina from the choroid. And on fundus examination, it gives appearance of excitative retinal detachment. So remember the other one we talked about endophytic, it was going towards the vitreous, right? Into the cavity. However, this one what it does is it separates the retina from the choroid. So you're able to see the separation, right? Yes, and if you do a fundus examination, you're able to see a feature of exudative retinal detachment. 3. Diffuse infiltrating tumors show just a plaque-like thickness of retina and not a mass. And such cases are usually diagnosed late. B. So now we go to painful red eye presentation. So when retinoblastoma is left untreated during the quiescent stage, some patients may present with severe pain, redness, and watering. These symptoms occur either due to acute secondary glaucoma or apparent intraocular inflammation or orbital cellulitis. Classification of retinoblastoma. So we had the Rees Ellsworth classification, but it's not used anymore, so we won't talk about it. Then the next one that we currently use is International Classification of Retinoblastoma, ICRB. So this is presently being followed worldwide to decide the treatment modality. So whereby stage 1 we have group A, which is very low risk. So this includes all small tumors less than 3 millimeters in greatest dimension confined to the retina, located greater than 3 millimeters from the fovea and greater than 1.5 millimeters from the optic disc. Group B, which is low risk, it includes large tumors which are greater than 3 millimeters in dimension and any size tumors located less than 3 millimeters from the fovea and less than 1.5 millimeters from the optic disc margin. Group C, which is moderate risk. So this includes retinoblastoma with focal seeds characterized by subretinal and ovitreous seeds less than 3 millimeters from the retinoblastoma. Group D, which is high risk. So this includes retinoblastoma with diffuse seeds characterized by subretinal and ovitreous greater than 3 millimeters from the retina. Then group E is very high risk. This includes extensive retinoblastoma that is characterized by any of the following. So whereby the tumor touches the lens, neovascular glaucoma, tumor anterior to anterior vitreous face involving ciliary body and anterior segment, diffuse infiltrating tumor, opaque media with hemorrhage, tumor necrosis with aseptic orbital cellulitis, invasion of first lamina optic nerve, choroid, sclera, orbital anterior chamber, or thysis bulbi. So basically, if we talk about group A to A, so group A is basically tumor less than 3 millimeters, confined to the retina. Group B, tumor is greater than 3 millimeters, confined to the retina. Then in group C, that's where we have got focal seeds, okay, from our actual retinoblastoma, right? So this is whereby you get subretinal and vitreous seed, but they're less than 3 millimeters from the retinoblastoma. Then group D, this one has got diffuse seeds characterized by subretinal and vitreous which are greater than 3 millimeters from the retinoblastoma. Then group B is extensive retinoblastoma. Or it can that is characterized by any of the following such as glaucoma, tumor that can be anterior to certain structures, where it gets thysis bulbi, etc. Okay. So this is whereby so basically how you can remember it's whereby you get some other conditions like you can get glaucoma, then it affects certain structures that are more anterior. Okay. So we now go to stage 2, which is stage of extraocular extension. So due to progressive enlargement of the tumor, the globus to the sclera, usually near the limbus or near the optic disc. It is followed by rapid fungation and involvement of extraocular tissues, resulting in marked proptosis. So if you're able to look at the image here on the left, you're able to see proptosis, right? You can see that the globe is bursting through the sclera, usually near the limbus, right? Then it's also followed by rapid fungation. Able to see that an extraocular tissues are also involved. Stage 3. So this is stage of distant metastasis. So this is characterized by the involvement of distant structures as follows. 1. Lymphatic spread which first occurs in the preauricular and neighboring lymph nodes. Then 2. Direct extension by continuity to the optic nerve and brain is common. So under this one, different literature have said different things. Others say the classification and on 3, others say on 4. So how they put it is stage 3. They said this lymphatic spread, and stage 4 is whereby it moves to distant organs. Okay, so other literature adds this stage 4 here. So whereby they spread distantly to the bone marrow, lymph node, bone, liver, but not the brain. Then 4b, this is whereby it affects the brain. Okay. So differential diagnosis basically under differential diagnosis we think of DTX of leukocaria. So this includes congenital cataract, inflammatory deposits in vitreous following a plastic cyclitis or choroiditis, coloboma of the choroid, retrolental fibroplasia, which was previously known as retinopathy of prematurity, then persistent hypoplastic primary vitreous PHPV, which also has a different name, which we now call it as persistent fetal circulation. So it's not known as PHPV anymore. Then toxocaria endophthalmitis and exudative retinopathy of course. Diagnosis. So diagnosis is basically examination under anesthesia. Then plain excess of orbit, calcification, and lactate dehydrogenase level is raised in aqueous humor. Then we've got ultrasonography and CT or MRI scanning. So these are basically diagnostic investigations, and we also have our baseline investigation such as full blood count, ESI, C-reactive protein, liver function test, kidney function test, chest X-ray, abdominal X-ray to rule out any metastasis. Treatment. So conservative tumor destructive therapy to salvage eyeball is indicated when tumor is diagnosed at an early age. So this is usually when tumor involves less than half of the retina and the optic nerve is not involved. For chemo reduction of retinoblastoma are as follows. So the drugs that we use are carboplatin, vincristine, and etoposide, which we call the CVE regimen. So there are two regimens here. So there's a standard dose CVE regimen. So this is for group A, B, and C patients, and then we've got a high dose CVE regimen, which is recommended for group D patients. Focal therapy. So depending upon the location and size of the tumor, focal therapy can be chosen from the following modalities. So cryotherapy, laser photocoagulation, thermotherapy with diode laser, plaque radiotherapy, external beam radiotherapy. And one thing you need to take note is if the above modalities are not available, the eyeball should be enucleated without hesitation. So if you're unable to perform any of the above, you go for enucleation. So enucleation, this is the treatment of choice for group A tumors, and when tumor involves more than half of the retina, optic nerve is involved, glaucoma is present, and anterior chamber is involved. Then we also have palliative therapy. So this is given where prognosis for life is dismal in spite of aggressive treatment. So this can be retinoblastoma with orbital extension, retinoblastoma with intracranial extension, and retinoblastoma with distant metastasis. And palliative therapy should include combination of chemoradiation, which is the CVE regimen, then surgical debulking of the orbit or orbital exenteration, and external beam radiotherapy. And one thing you need to take note is exenteration of the orbit is not preferred anymore. Okay, it used to be performed in the past, but now it's not preferred. So, prognosis. If untreated, the prognosis is almost always bad and the patient invariably dies. Really, spontaneous regression with resultant cure and shrinkage of the eyeball may occur due to necrosis followed by calcification. That suggests role of some immunological phenomena. Then, if the eyeball is enucleated before occurrence of extraocular extension, prognosis is future 70 to 85% survival rate. Then, poor prognostic factors are optic nerve involvement, undifferentiated tumor cells, and massive choroidal invasion. So one thing you need to know is if it's untreated, prognosis is bad. Basically, the patient will die, right? However, very rarely they may still be spontaneous regression. Okay. Then we also have thing that if we perform enucleation before there's any extraocular extension, the survival rate is 70 to 85%, which is good prognosis. Okay. Then poor prognostic factors are if there's optic nerve involvement and differentiated tumor cells and massive choroidal invasion. So that's all about retinoblastoma. If you like the video, please like, subscribe, and comment. Thank you.